Kia ora tātou, everybody. Bruce Arrell's my name. I'm the director of the Goodfellow unit and head of Department of General Practice and Primary Healthcare at Auckland University. Tonight is a webinar on COVID in the home, what primary care needs to know, and it's being funded by NRHCC, who are the Northern Region Coordinating Centre. They've already supported us for one of these. I'd like to thank our audience. We've got a very exciting panel tonight, and I'll introduce them as we go through. You'll see the names up there. Some of them you'll know, some of them may not be quite so familiar. So the first speaker tonight is Dr. Gary Jackson. Gary's a public health physician from counties Manukau. He's been in and out of the DHB and the private sector and well known for his data analytical skills. He's going to set the scene and just give us a few slides on what's been going on with the current pandemic. So over to you, Gary.
Kia ora koutou. Thanks, Bruce. What I'm going to try to do is just set the scene up. So I'm going to start off talking about the Auckland outbreak and then just move a little bit into the resiliency planning that the DHBs have underway. And that should hopefully set the tone for the background for the other presentations. So probably most of you are familiar with the outbreak curve from the Auckland-based outbreak. An initial very rapid rise with an R0 of around 6. So the Delta variant showed its paces and what had been a level 1 socially mixing population, and the spread was remarkably rapid. So even though we went into level 4, as fast as you possibly could have, there was still a reasonably large outbreak. The level 4 worked and the public health response worked and the cases came down, but then the virus spread into different populations. One thing is very interesting from an epidemiology point of view is that normally case curves, you draw exponential curves through them. And if you look at the up curve on the right-hand side, it's more of a straight line than a curve. And that's kind of a mark of how well the level 3 restrictions were still having an effect, and also how well the public health scramble was able to keep kind of on top of the virus without actually getting rid of it completely. So if we extrapolate the outbreak forward, so the worm is that orange line in the previous graph, just average for 3 days, and working with TPM with Sean Hendy and Mike Plank, we did a variety of projections around where this is likely to go. And essentially we chose sort of a mid path of a likely growth, allowing for the vaccine, because of course, since the outbreak started, it's done wonderful things for the vaccine rate. People have suddenly seen some good reasons to get vaccinated. So we've had a good uptake of the vaccine, and that's already starting to reduce the pool of victims for the virus to circulate through. This graph also shows you the exponential lines that I mentioned. So if the cases have been growing at those R levels, that's where it would have been heading. At the moment, we're hopeful that we'll end up somewhere topping out at around 200 cases a day. This is for the northern region, Metro Auckland really. So somewhere between 100 and 200 cases a day is where we're projecting if the vaccination rates keep on going how they're going, and there's no large change in people's social mixing, then this is a potential scenario that we're hoping might come true. There's lots of projections or ways you can project that would show a much higher growth, but at the moment, things seem to be holding quite well. If that does come to pass, then you can extrapolate how many hospitalizations and the ICU occupancy that then generates. So again, this is for the Metro Auckland area, and Dr. Colin McArthur, who's an intensivist at Auckland, did these graphs, simulations for us. So it looks like by the end of November, you're likely to have between 85 and 120 people in hospital at any one time with COVID. So that's about a ward full for North Shore, Auckland and Middlemore hospitals, and so 30 patients apiece, and probably maybe 6 ICU patients at each of those hospitals. So that's if we were following that upper projection on that projection. And usually from that, you can then start calculating how many people are isolating at home, how many people are going to have a more severe illness and therefore need primary care support and so on. So the numbers can drive off that. Then the next step, so moving away from that outbreak now and thinking about longer term, the DHBs have been thinking around what's the state for next year. So assuming that we're not going to do lockdowns forever, that we're moving, since been announced, the traffic light system, but prior to that, we were trying to predict what was likely to happen. So we did a program where we've divided the population into those who are vaccinated and those who are unvaccinated, and used a sort of matrix like shown on the slide here, by age, by ethnicity, and just imputed some potential vaccine numbers, so vaccinated population. This particular grid's actually for counties Manukau for my DHB, and the number at the bottom right there at 90%. So the scenario is saying we'll get to 90% vaccination rate for ages 12 and up. But for counties, that only equates to 73% of the total population, the all ages, because we've got so many 0 to 11-year-olds. So we're watching with great interest the discussion around whether 5 to 11-year-olds are going to get vaccinated. That will make a big difference, I think, to the pool of people who are susceptible to the virus. So for each DHB, you can calculate then based on the various assumptions that the TPM modelers have done. You can calculate sort of an average for 2022, that how many cases you might expect, how many hospitalizations, and how many deaths from the virus as it starts to circulate through the community. So as we open up our borders, we're not trying to eliminate anymore, we're trying to suppress, we're trying to live with the virus, and we're assuming that enough people are vaccinated that we'll be able to do that. So at the moment, these numbers are for the northern region, but the numbers are available for each DHB. There's a central TAS in Wellington has produced a Power BI version of this, which each DHB has access to, and they can construct their own scenarios. It's not a prediction, it's not a forecast, but it's just a way of setting up different scenarios so that you can test your systems against the volumes that might be expected in each of these scenarios. So for example, in the northern region, we've been using that white line as saying this might be our steady state, what we'd expect. Coincidentally, the 600 cases a week that it's suggesting is what we did last week in Metro Auckland. So it gives a pause of thought for hospital managers to think about how well did we run last week, and how much elective surgery did we not do? So how can we run our hospitals and do our outpatients and our elective surgery while managing that many COVID patients? So there's going to be some interesting work around how we do our red lane, green lane, or how we operate with that sort of context. And then we're assuming that there's going to be a surge at some stage as things loosen up. And so therefore we're thinking we might have to look at a scenario where we had 3,000 cases in a week and then 150 hospitalizations, and how would we manage that? So that's the kind of thinking that's starting to go on in resilience planning inside the DHBs. And you can use these numbers, usefully can use these numbers again to calculate your primary care loads as well. And the last graph that I'll just throw up is one that I've seen a number of people use. This is just comparing the vaccination status of the population versus the vaccination status of the current cases in the current outbreak and the vaccination status of the current hospitalized patients. So 15% of the population are still unvaccinated, not even one dose, but 88% of the hospitalizations from people who are unvaccinated. So it's a pretty easy message to state there. I'll stop there, Bruce. And
thank you very much, Gary. We're going to keep the questions till the end. If you have questions, put them into the Q&A box. Our next speakers are Dr. Lance O'Sullivan, who won't need much introduction, very well-known GP and former New Zealander of the Year. He's going to be talking about the experience in MIQ with Stephanie Hlohovsky, who's a nurse practitioner who's been working with the COVID positive patients in managed isolation. So welcome, Stephanie and Lance. You two probably have the most experience now in New Zealand of dealing with the sort of patients we're going to be getting in primary care. So over to you. We've got 20 minutes, folks.
Oh, kia ora, Bruce. Thank you. Yeah, just I guess, as a GP and a rural hospital practitioner who's working in MIQ, we've, especially coming from a rural background, has seen the restrictions and limitations of trying to look after people, primary care needs and COVID complications without really access to investigations and referrals onto specialist services because of the fact they're in quarantine. So that in itself has created quite a few challenges. Coming from the area I've come from, it's sort of, there's a bit of background that I've experienced, that I've had, that's allowed me to sort of work a bit easier in that space. But look, I guess what's, it's incredibly challenging is we're seeing a lot of Māori Pacific people coming into MIQ with COVID. The complications are seen a lot in the younger unvaccinated population. And it's interesting compared to last year when I was working during the August outbreak last year, and it was largely the older population of people that were getting sick. And obviously the vaccinations made a big impact on who we're seeing now getting sick. But obesity related risk factors, and diabetes, heart disease, etc. Stephanie and I have been working in the MIQ for a wee while, and as Bruce said, we've probably been at the sort of sharp end of the management of people with COVID in New Zealand. And now I've also been looking after people in the community recently who are quarantining at home as part of the COVID care in the community. And that poses some additional challenges, which includes just simple things like trying to get hold of people is incredibly hard sometimes. And we're doing that because we're trying to check on them every day from a clinical, are they well point of view, but also from a public health point of view, are they ready for clearance? And I suspect that that's going to be a part of primary care's role into the future, potentially, is clearing people from quarantine. But that's very hard, just a simple thing like trying to get hold of people. Getting monitoring kits to people in the community has been challenging. Recognising the importance of those at highest risk. Last night I had a 21-week pregnant lady who we didn't know about for a day and a half, 36 to 48 hours. She was positive, but we hadn't got her into our regular monitoring and screening schedule, and that could be quite a big risk. A Māori 21-week pregnant lady in South Auckland. So we've got to try and find ways to get around barriers to getting them oxygen monitors and things like that. Last, I think 24 hours ago, it was just that they didn't have her on the books, and we just have to, last night I got someone from the Holiday Inn MIQ just to put in an Uber and deliver it to her house, and we got her sat at 10 o'clock at night. So I guess it's just going to have to be really innovative and figure out how we can get the care to the people. Stephanie, I would like to introduce, who's been probably more at the sharp end than I have in recent times, working out of Jet Park, looking after hundreds of people with COVID, and she's got heaps to share from an experience point of view. Thanks, Stephanie.
Thanks, Lance. Thanks, everybody. I think we sort of learned trial by fire. I think it all hit us in August, and we were cruising along with border cases coming in quietly, and all of a sudden, bang, we had this community outbreak. It's changed. The outbreak has changed quite a bit in the demographic over the last 2 months. It started with a very large Samoan church cluster, and I think vaccination has had an impact with that population, because I think when it started, we did see a lot of older, like sort of a plus over 60s, large families. And I think this is an amazing opportunity for people to be in primary care, because I think we've all felt uncomfortable at times pulling families out of their homes, large families, specific families with their support networks, and trying to manage them in managed isolation. So I think primary care is the best place has a great opportunity here. I don't know if Lance, but we talked about a few cases, and I think they present, for me, my background's critical care, so I'm used to seeing sick people, but I think these people present very differently. So I think that's probably one of the key factors. With a normal sort of viral illness, people present and they start to get better. I think for the big telltale sign for me was people come in, they're pretty okay, and then at about day 6 or day 7, they deteriorate, and they deteriorate quite quickly. And one of the best things that I think I could recommend is having the relationships with the other organizations. I think we have morning meetings every day with counties and the regions, which has made a huge difference as far as communicating and sort of discussing cases, getting patients into the right patients into the hospital at the right time. One of the cases that I just thought I'd give a few examples. We had a woman, like Lance said, we had a young woman, 33-year-old Maori, unvaccinated, sort of had come into MIQ day 3 or day 4. She started getting a little bit short of breath, but wasn't particularly unwell. And then by about day 5, day 6, she was significantly just doing anything. And the lovely part about MIQ is you have nurses on site 24/7, and people can call down. And I think people feel that, feel a bit more secure than they necessarily would be in the home. And the other luxury about MIQ is you can go and review somebody, and then you can go back a half an hour later, an hour later, and see them again. And then you can make a call whether you need to send them to hospital. But this woman was 33, no other comorbidities, looked really well. And then within the space of a few hours, she had really deteriorated with breathlessness. Her sats were actually fine. They were about 96, 97%. But I think by the time I think Tim Cutfield's on here, but I think by the time she got to hospital, she ended up over the next day, ending up on high flow oxygen, and she had the full works of treatment. The complexities around safety, she basically was a solo mom, had an 8-year-old child, couldn't leave the 8-year-old in MIQ by herself, so I had to sort of figure out the safety net, and actually Middlemore took the child and the mom as a unit into hospital. So I think having those relationships with tertiary care makes a big difference. We also had another young 34-year-old Maori guy who looked really well, went up to see him, said he was a little bit short of breath, but nothing else, and put the saturation monitor on his finger. It was like 89%. And then, you do the normal thing. Oh, it can't be right. Change probes, change sat machines, keep looking around, because he didn't look that unwell. But he ended up within about 6 hours of getting to hospital, ended up on high flow oxygen as well. So I think it's kind of picking up those subtle cues and knowing when to get them to the hospital at the right time.
Can I just add, in terms of Stephanie's example she's given, is the limitation for primary care is that you may not be able to go and see these people. You may not have RNs that can, go up 2 or 3 times a day, obviously, and do observation. So it's going to require good understanding of the people you're looking after. So that's inherent in the fact that you're the general practitioner, listening to their family and their loved ones, because if they highlight concerns, that's really important. We should take that seriously. Using any monitoring equipment you have, and making use of video consults. We do quite a lot of video consults, and that can be quite useful. But at the end of the day, it's still going to pose significant challenges. But yeah, thank you.
Lance, well, I saw Dee Mangin talking. She was saying in Canada they asked people if they were saying better or worse, and then that's how they did the monitoring by phone. And if people were getting worse, then irrespective of their O2s, they would send them along. But she was saying there's a fairly predictable path for most people. Is that correct? Who are COVID positive and well, and then so many days they become unwell. Could you comment on that?
Yeah, certainly, towards that day 5, 8, that's that risky period. I think, just thinking about the people I've spoken to, and, I'm sure Stephanie will say the same, is you can typically hear quite early when you're just talking to them on the phone, they're short of breath, And so, again, I like this just simplistic approach, which is, saying better or worse. Keeping it simple is going to be really useful. And realizing that, people can be quite hypoxic actually still, and without, symptoms. And that's why the monitoring is going to be really useful for those that you consider high risk.
Do you rely on the stats? There's a question there, at what level would you consider sending someone to hospital irrespective of what their condition was?
Yeah, I think, Stephanie, you may have an answer for this too, but it'd be, I've sent people to hospital that have still got reasonable sats, but are in quite a significant amount of respiratory distress.
Yeah, I would say we normally, like anything below 93, we generally would phone, at least get some advice from the COVID clinicians, particularly if they have risk factors. I think one of the interesting things with this outbreak is, Lance might remember this, is for the first few weeks of that outbreak, people were really sick without respiratory symptoms. They were really febrile, and everybody seemed to have like severe, like joint pain and nausea, vomiting. It didn't seem like a respiratory illness for the first few weeks of the outbreak. And then the respiratory people sort of present very unwell, very flu symptoms. And then they seem to be those patients that have high temperatures, really unwell, seem to be the ones that progress down that pathway.
What we've also seen recently is quite some reluctance to go to hospital. So, that's something that just around education, having daily checks from your team on these unwell people early is going to be really important to, predict, and detect those trends when they're changing, and also educating them early in the illness around how things might go. It's going to be very important.
Any comments on managing children? Question here. Any differences, or what are the experiences of children?
Stephanie's looked after quite a few children with her pediatric backgrounds, very well placed to comment on this. But I mean, I'd say we've seen quite a few children that have done very well, far better than the adults. So Stephanie, do you have a comment?
I would say the same. We have sent a few children to hospital. I think the ones that we've sent have been quite small, young. We had a couple of neonates, or fairly new, first 6 weeks of life that we sent into Starship. But most of the children have done well. I think the big thing is sort of being fever for a day or so, and then just managing fluids. But from the respiratory point of view, I think they've actually done quite well.
We currently have a 12-day-old or 13-day-old in MIQ who's got COVID, who's COVID positive. 2-month or 1-month-old. We had a child who was awaiting liver transplant in the last year in MIQ. So yeah, it's quite daunting, but actually the children do very well. And the flip side of that, we've also had vaccinated 90-year-olds in MIQ that have done really well, which is really encouraging. And keeping in mind, it's that 30 to 50-year-old age group that's getting quite sick.
Got a question here. Are nocturnal symptoms deteriorations common in these patients? Like, I guess the troops are wondering if they're going to be called out of bed in the middle of the night.
We refer quite early. That'd be probably the best answer, Stephanie. As a good working relationship with the ID teams in across the hospitals has been really valuable, and they've been really supportive. And if we're worried, refer early. We certainly have referred people overnight, but good planning should avoid sort of the 1 o'clock referral.
Okay, we've got a few questions here that I can probably, the home oxygen options, are there any home oxygen options at the moment?
No, and I think anybody who would need oxygen, I think I watched one of Dee's talks and she talked about except for in the palliative care, if somebody doesn't want to go into hospital, and but we haven't even explored that option. Tim might be a little bit more aware.
I suspect until we get really pushed from a resource point of view, that would be something that would be further down the list. But we don't put people on oxygen at MIQ for that reason, is that if we believe they need oxygen, they shouldn't be in MIQ. And that's the same at this point in time. It should be the same position that primary care takes.
Alan Moffat, the medical director of ProCare, has said MOH have a central supply of oximeters, and ProCare also has several hundred. So So it sounds like the supply is pretty good.
In the context of trying to do virtual consults, it's critical that if you have people that you're concerned about, they have a monitor, and it may only be for 48 hours, 72 hours, move them around to, triaging them to the best and most important place to be used.
Got a question here that might link up when we hand over to Tim. How do you see the relationship between GP and secondary care as described by secondary as being needed for facilitating admissions? Sounds like you guys have got a fairly special link up. Any advice for the troops?
I think for me, the relationship, like it's been probably one of the most productive meetings I've ever been in while I've been in my career in healthcare, is our meeting with the COVID teams from all the DHBs. And I think we feel very supported, and we can call anytime if we have questions. And I think having that access, I don't know how would setting something up so that there's a set time where people can contact a COVID person, I think would make a really big difference. And I think it'll be interesting what Tim said, but I think, we've never had any pushback. It's been really good when you send people in, they get in very quickly.
Another comment here from a doctor saying pulse oximeters are easily sourced through counties. So probably another question that Tim can, if Tim maybe I'll answer that one too. So,
hey Bruce, just one final comment, which would be, the psychological impact of people who are COVID positive can't be understated. It's a significant burden on people, and so, and that can you can get anxiety related symptoms overlaying actual true respiratory COVID related respiratory symptoms and other symptoms. So look, the people are going to need a lot of support, and the best people to be delivering that is actually those that they know and trust. So it's a big task, but it's going to be good to have that existing relationship is going to bring a lot of benefit to how we get through this.
I remember you saying to me, Lance, about 20% of people have a sort of psychosocial sort of issues. So that's something we're going to have to be dealing with. Okay, well, thank you, you two. So I think we're going to have a lot of questions coming up, and we've got a good team. So I just want to introduce Tim Cutfield, who's an ID physician, and he's going to talk about his experience overseas. And he's currently in Middlemore Hospital. Presumably you're linking with Stephanie and Lance over these patients. Tim, over to you.
Thanks a lot, Bruce, and really nice to be speaking with everyone online, and love to be part of this panel. I guess just picking up where you left things, Lance, in terms of the psychological impact of COVID, it's absolutely right. I didn't start feeling breathless until my mate called and told me that I was positive. Back in March last year, it really hits you like a truck, and so dealing with that is something that's really important. So I'm going to talk a little bit about what New Zealand has dodged, really, and then a couple of lessons that we can take going forward. So my fellowship was meant to be in tropical medicine and travel, which was just terribly timed by landing in London in February. And I was meant to be in this shiny, I don't know if you can see my pointer, but the shiny big building on the left was the hospital I was in, 16 stories. By April, 9 of those were full of COVID patients. This is me on the right with a duck-billed thing in one of a slightly old picture, but of one of our early COVID wards. But anyway, in that first wave, when 20% of London got sick all at once, the NHS was breaking. People were not coming into hospital because they were protecting the NHS, and we were in touch with colleagues and myself at home as well, who were sick but were unable to get into hospital effectively. The ambulances weren't there, and it became rapidly apparent that there was a model of care that needed to be delivered to people out there in the community. And this is before there was any data to inform this. So we sort of built, scratched together a virtual ward from just what we had, which is a whole heap of very junior travel docs lying around. And the sort of priorities of this changed, but effectively because what we were dealing with was people pitching up to ED sick with COVID rather than any early testing. It was initially calling people who'd come to ED and letting them know their result, which public health were just too overwhelmed to do. And then it became realizing, oh, well, we can actually follow these people who are positive up and follow them through their illness, make sure they're okay. And then it became, there's far too many of these. We're going to need to just follow the people with the highest risk factors of deteriorating, which, you know, we were getting some more information about how to pick those. And then we started, when the hospital started to get overwhelmed again, really dealing with the highest risk ED, outpatient cohort you could imagine. So the people who were too sick to be in the, looked after in primary care, but not quite sick enough to be in hospital because the hospital was absolutely full. And we were picking people up who had just reached a threshold where they didn't need continuous oxygen in hospital. So by the end of things, well, this isn't the end of things, but this is a little snapshot in the red, which is the second wave over winter. We were caring for, I guess, a cohort of people who really benefited quite a lot from having, virtual ward involvement. And you can just see, look, the impact of the timing of vaccination. And we'll reflect a little bit about how that changed what we saw. This is data, and this evening's not really about data, but this is just a little snapshot from that highest peak of about 650 people we saw. And the point of the numbers is not the absolute numbers themselves, but is how they sort of combine into making risk scores. And Lance and Stephanie have already talked about, trying to pick people who are higher risk of deteriorating, and so incorporated in all sorts of guidelines employed overseas and are going to be adapted for our situation. There are certainly a list of comorbidities that will predict your risk. And so the chart on the right is, it talks about the C-SIQ score, which is a UK score. No score's perfect in this, but really what the C-SIQ score did was pull together a number of those biggest risk factors for doing poorly in the unvaccinated situation. So that was primarily age, male sex, some of the other comorbidities, what your oxygen sats were, yada, yada, yada. So the things that people pay attention to and will be watching from a primary care and secondary care perspective. And I guess what I wanted to show you this for was that the top bar, box and whisker, that is the people who needed to come back in to hospital after being in the community, which was about 10%, I think, of that cohort, compared to the people who didn't. There's a significant or significantly significant difference in those risk factors, but there's still a lot of overlap. So I guess the message is that while the risk factors are important for trying to pick the people who are most likely to run into trouble, you still got to deal with the person in front of you, regardless of what the risk factors are. And like Lance had said, pay attention to what they're telling you and what their whānau are telling you to pick what's going on. This is from the same data set, and again, the numbers aren't the point. I don't know if you can see my pointer, and if you can't, it doesn't matter, because I hope you can see this is CRP on the vertical axis by day of illness, stretching out to 52. And there's, if you use the eye of faith with the box and whiskers by day, you can sort of get the feeling that there's a sort of a bimodal peak. Now, this was alpha variant. Delta probably brings this forward a couple of days, but most people will be at their most inflammatory state sort of between day 7 and 10, or day, onwards of day 5. And that's sort of where we put in the guidelines, why you keep a risk eye out for people as they go into that area. And then there seems like there's a second little peak later on. And what we observed was that particularly the older unvaccinated, of which is very few in New Zealand, thankfully now, they might tip over a little bit later. And so again, just keeping an eye on people. Are you getting better? No, you're not. And if they're not, and they're just staying the same, just keep an eye on them that little bit longer to make sure that they really get out of that risk window. So when you're setting up a virtual ward from scratch, there's all sorts of things that you learn. Thankfully, in our environment in New Zealand, we can learn from other people and learn from each other. But like Lance said, and I had personal experience as well, it's scary being diagnosed with COVID, and particularly in the New Zealand setting where we've pursued elimination and COVID has been something that other people see. It's going to be a lot of fear. And so normalizing the experience and explaining what's going to be expected is going to be a really big part of the initial contact. And then the burning questions, the important personal questions, might come later on once you start to build that relationship. And I think that's one of the really key things with if you're looking after people who already know you, so their primary care provider, you've got that relationship and you can jump to the important things earlier on. This might seem a little scary hearing, about a completely new condition and experiences of what can go wrong, but it doesn't take long to get a feel for what's going on yourself. And when you're calling on, particularly helped if you've got some other colleagues who you can talk to. And as Stephanie said, that's what we've been trying to foster, a sort of relationship so that we can talk through cases where there's some uncertainty. And so we can all learn together rather than trying to learn over time. And at the tail end, and we haven't really focused on this and probably won't today, but we found it quite useful to be able to tell people who do have persistent or, slowly improving symptoms to say, hey, look, if you are still symptomatic at point X, this is what we'll do. So there's some framework to the recovery, and I know that that's being factored into the local response. So thinking about the people who are unvaccinated, and that's what we saw for 12, 13, 14 months, which was pretty hard yakka. The oldies present like oldies do, with geriatric giants, when they come in from the community, particularly troublesome delirium in the older patients. We saw a couple of cases of really severe postural hypotension, which was, to the stage where people couldn't walk for a couple of weeks in some cases. And I talked about the slightly later peak in some of the old people. Having said that, a lot of people, in fact, the majority of older people did okay and did fine. And so I guess when you do get older, if you do happen to get an older person who's sick, it's not all doom and gloom, right? You're there to monitor them, but the majority statistically will do well. We've talked about young people doing well. They do tend, in my sort of observations, maybe have a little bit more of the dysautonomic stuff, like a bit more tachycardia, maybe a little bit more feeling fainty, and occasionally, and in some ethnic subgroups, maybe a little bit of inflammatory stuff, a little bit of joint pain that we alluded to, or occasionally, really persistent low-grade fevers. And if you end up running into any of those, that's a sort of good time to call for help and talk about it. Although even then, most of these people gradually go through that phase. The middle-aged groups are a real mix. Some will do absolutely fine. Some will get very, very sick, slightly unexpectedly. But again, I think that's pretty well encompassed in the risk factors. And just to touch on, we've already talked about pregnancy really, and people can look sicker than their numbers. So if somebody sounds sick, even though they've got normal SATs, yeah, good time to get them checked out. And the immunocompromised hosts, it's a completely different, talk. We would be very happy to have calls if you've got one of your patients who's heavily immunocompromised who gets COVID, and that's a good sort of secondary and primary care interface to talk about how to approach that. I guess we were doing our virtual ward completely over the phone. The NHS wasn't flush with camera phones and things, which we should have, but we didn't. And so we were doing a lot of remote contact over the phone without oximeters for a significant portion of this. Oximeters completely changed the game, and I think a really important part of the rollout. But things that would worry me if I was speaking with someone over the phone and I didn't have oximetry would be, some of these things: too tired to get out of bed, or too tired to walk to the toilet. And that's sometimes what those silently hypoxic, I'm not breathless, but I'm hypoxic, people might have said. Memorably, and uninterruptible coughing. You can't get a full sentence out of these people because they're just coughing and coughing and coughing and coughing, even if their oximetry is normal. We had one of the charge nurses on one of the medical wards upstairs was like this, and she wouldn't let the ambulances into her house because of fear of coming into the hospital, as Lance had alluded to. But the message being, really, really uninterruptible coughing is a worrying sign. The chest pain's a tricky one, and chest pain is something that certainly we need to pay attention to, but it's really common to get some pleuritic chest pain early in the phase of your COVID illness. And usually if it's coming along with everything else and the person's not that sick and it's come on gradually and going away gradually, then that's okay. But the thing that would worry me is if somebody's gone through that phase and they're saying, oh, I'm feeling better, and then a couple of days or often a week or so later, then they get a bit of pleuritic chest pain and maybe a bit of breathlessness. And that would be the thing that would trigger in my mind that person's worth checking out for a PE. Obviously, if someone's confused or drowsy, that's bad. And if they are still really febrile after day 10, for me, that tended to be a little bit of a warning for maybe things, this person's not fighting off this virus as adequately as we might like. And so in my mind, that was a bit of a warning. And then vaccines came along and the world was a better place. The hospital was just completely chocker all through winter. It was a terrible, terrible time. And then vaccines came along and it's just been manageable. Even to that third wave, it was just not completely different treatment landscape in managing people in London. You'd see people who were positive, but they were asymptomatic, or they were minimally symptomatic, or they'd have an illness and they'd be sick for a week or so, but it was so mild compared to that same person or that same, combination of comorbidities and age that you would have seen in the unvaccinated cohort. So no doubt in my mind, seeing it firsthand how well vaccines worked. And then the depressing part of being on a ward in a post-vaccine world is your ward is unvaccinated people, unvaccinated people, unvaccinated people. And then the very, very frail, who are immunosenescent, and the occasional person who's very immunocompromised. And because of the vaccine rollout, we're going to select for people who are positive, who are unvaccinated, and then there will be some people who are COVID deniers. And that's really emotionally and psychologically difficult for medical staff to deal with. I would just psychologically, if you do come across someone like that, think of it like a delusional disorder, and some of the same skill set that primary care would have developed for approaching people with delusional disorders might be useful. So, sorry, there's quite a few slides there, and I've ripped through deliberately quickly, but I mean, COVID care can be challenging, but I think it's really interesting. And you know, my personal experience of being on the other side before any of this virtual stuff was there, and then speaking with patients on both sides of the fence, I've no doubt in my mind this is critical work, and you really, by providing care in someone's home, significantly improve their quality of life, their journey through this illness, increases patient safety in terms of facilitating hospital admission in a timely manner if they do need it, and it's really rewarding at a personal level to be able to see people through that journey and out the other side, and I'm sure the others on this panel will agree with that. And I think we're in a really good position to be able to do this really well, particularly compared to other countries that have had to sort of, you know, do things from the bootstraps up. We can learn, we can take the best of what's been done overseas and apply it here with the, you know, pragmatic attitude that New Zealand has done for a long time. So I think it's an exciting space, and we've got an opportunity to do it better than anyone else. I think that's all I wanted to say. Thanks, Bruce.
Thank you, Tim. Obviously, a trial by fire to you, not what you expected, but nice that you can bring that the skills you've learned over there and the experience. It must be very valuable to you at the moment. So the next speaker is going to be virtual. It's Professor Dee Mangin, who many of you will know from Christchurch. She's now Professor of Family Medicine at McMaster Medical School in Canada, and she's recorded this because it's 2:30 in the morning in Ontario, and we didn't think we could wake her up in the middle of the night to do this. So over to Dee.
Kia ora koutou, everybody, and good evening. In the next 10 minutes, what I'd like to do is share with you my experiences over the last year as medical director of our community COVID ward at our family health team, where we cared for over 600 COVID positive patients now and growing, and as medical lead for that model as we scaled it across Ontario, which has a population of 17 million. And you can see this is the context in which we were working. At its peak in April, we were seeing over 4,000 new COVID cases per day. In this 10 minutes, I'll only touch on things lightly. And so if you want more detail, there are two resources here. One is our detailed clinical pathway for primary care of COVID, which guides you step by step through everything you need to know. And the other is a YouTube video, which is a much longer webinar covering the things that I'm going to just touch on tonight. So why primary care? Well, because it's evidence-based. We know that outcomes are better when primary care systems are the strongest for these reasons. And also because COVID is, after all, mild to moderate infectious disease in 90% of cases. And this is our lane. We know how to manage this. It's not rocket science. It is very infectious and can deteriorate rapidly, but we're used to detecting when mild to moderate infectious disease has become more severe and needs hospitalisation. And it is a viral, community-acquired, largely pneumonia illness. And also because knowing a patient well is an extremely potent asset during a pandemic. Our generalist approach is our superpower, and many of these patients have comorbidities that need management as well while during their COVID illness. And also the importance of relationship. I have no evidence, but I am convinced that this familiarity in unfamiliar times is a really potent therapeutic tool for helping mitigate the anxiety that goes along with a positive COVID diagnosis and isolation. The key elements of our primary care model for managing mild to moderate COVID and palliative COVID were these: a really simple systematic approach to patient risk assessment to determine the monitoring frequency, an evidence-supported pathway to support this, a supply of pulse oximeters, and that's key really, pulse oximeters are to primary care for COVID, what ventilators are to hospital-based care. and a systematic approach to make sure that no one falls through the gaps. So we had a register of all our currently active patients for our family health team, just to make sure nobody fell through the gaps. What are the goals? To get people who need hospitalisation into hospital as early and quickly as possible. To maintain hospital capacity, though, by avoiding sending to hospital those who do not need it. So being able to manage those in their homes who don't need oxygen support. And to reduce the isolation from family by providing ordinary COVID care and also palliative COVID care in the home. We all saw those tragic stories, especially from Italy, of older adults dying separated from families and saying goodbye over iPads. And it doesn't have to be elaborate to be excellent primary care. You just need the doctor, the patient, a way of communicating, which we've all learned now in these virtual care times, plus or minus a pulse oximeter if their symptoms and risk determine that they need it. So into the weeds of clinical care for COVID and primary care. You can find all the resources that you need on our pathway here for assessment, monitoring and managing of COVID. And I'm really going to focus on these two salmon-coloured bars on how to go about monitoring and follow-up and how to manage COVID illness in primary care. So the first thing, as I said, when you get that positive COVID result for your patient is to think about what's their risk of serious illness. So to risk stratify. And this will tell you how often you need to monitor the patient and whether they need a pulse oximeter or not. And you can see here, it's all the things that you will already have learned about COVID illness. Really, anyone that's either older, or that has any medical comorbidities, and the epidemiological data isn't really secure enough to decide which comorbidities are in or out yet. So anything that requires long-term medication, including hypertension, things like that, are in this higher risk grouping. And also anyone that has safety net flags, social safety net flags. Plus also anyone who's in this low risk group, so otherwise healthy younger adults who have no comorbidities or flags, anyone of those who have deteriorating symptoms automatically flip to that high risk group that you should monitor much more closely. And just an important thing to note is the time course. So change is your friend here. It's really the key to everything. And that's why we, rather than waiting for patients to get more ill and come and see us like we do with normal infectious disease, we monitor them from the outset, because then you have the baseline when patients are relatively well at the beginning of the illness, and then the deterioration tends to come around sort of 5 days and beyond, as you know. And the median time from symptom onset to dyspnea is around about 5 days in those who require hospitalisation. And in people who develop ARDS, the median time is about 3 days after the onset of that dyspnea. So being able to have those baseline values and be able to see the change really clearly is really important. And then the monitoring a template, again, is not rocket science. It's how does the patient feel? What are their vitals today? What is their dyspnea like? And how does it compare to yesterday and the day before? Change, that is the key. And are there any comorbidities or medications that need managing alongside that? Also looking at red flag symptoms here. And I'll talk about that in a bit more detail in a minute. But they're really the kind of red flag symptoms that we would look at in ordinary community-acquired pneumonia that would make us admit the patient to hospital. Management of COVID, again, is very straightforward, and patient advice is the key to these domains of management. And again, it's very straightforward. It's setting expectations for this illness. This is not just a normal viral illness. Explaining to patients and giving them a handout, if you can, what to expect over the course of the illness, what symptoms they would get, and in particular, what to watch out for at that sort of day 5 and beyond point. Rest is really critical in this illness, and fatigue is often a marker for hypoxia, and experience with Warren Well patients tells us that increased mechanical work of breathing can lead to increased lung damage. So it makes sense not to do anything that triggers dyspnea or tachycardia. If patients have pulse oximeters that they can measure after different activities, this is a way to reinforce this message. Breathing, while there's no evidence for prone lying and position changes in the primary care setting, it makes sense to decrease the mechanical work of breathing. And certainly our anecdotal observation of patients was that when they changed position and went into the prone position for periods of time, it improved their SATs on their pulse oximeter. Safety netting, of course, is really important. Letting them know what those red flag symptoms are and who to call when to call you in the clinic or when to call the ambulance, and making sure that they have a copy of those instructions and that their family members do, so it's clear. And our usual instructions around hydration and of course, isolation. Treatment, again, is very straightforward. Just don't, mostly. And on the HFAM pathway, you'll find links to the evidence for not giving the variety of treatments that have been flying around in social and other media. Comfort medications, paracetamol makes sense because we know that even with short-term illness, not specific to COVID, but in those patients with multimorbidity, anti-inflammatories do increase the cardiovascular risk in any viral illness, even with short-term use. Existing medications, it's just business as usual. But do remember to look after the kidneys. So think about acute kidney injury risk, which we do see a more serious, as a feature of more serious COVID illness. Are they on any of those SADMAN type medications and diuretics, ACE inhibitors or aspirin, that we maybe need to pause if we're worried about them getting dehydrated, if they've got nausea and vomiting or diarrhea? Do we need to pause them for a few days to reduce that risk of acute kidney injury? And with immunosuppressants, consult the relevant specialist to decide on whether the risks of continuing outweigh the benefits. When to refer to ED. So again, it's actually, we find it's very obvious when someone needs to go to the emergency department, and it's those same things that would always prompt us to send someone into the emergency department. Worsening respiratory function, so either reaching critical levels with saturation, so less than or equal to 92%, or a change in 3% over a fairly rapid period of time, even if they haven't yet reached 92%. Increased work of breathing, even if they're maintaining their SATs, so tachypnea, breathlessness, or that they're having real difficulty with the work of breathing. The other things that would always lead us to send someone to hospital: pain or pressure in the chest, shutdown or dehydration, cyanosis, confusion and difficulty to rouse. Again, all things that we would always recognise and will always trigger us to send someone to hospital. Important to get local connections with your hospital to figure out those processes for efficient transfer into hospital. Developing a straightforward way to record this in your EMR or your PHR. And this is an example that we used. I think the key part of it is just having a way in your notes to be able to see easily the change in both symptoms over time and vital signs over time at a glance without having to scroll. And also flagging any of those other important areas that might need attention, mental health being particularly important, but also those social circumstances that will enable people to be cared for safely in the home. So knowing a patient well is really potent during a pandemic, and equipping family doctors to leverage that relationship in a proactive way is really important as well. So these are just some final questions to consider. What will it need for your practice or local region to be ready? And what existing relationships do you need to leverage? So a close working relationship between local primary care and public health is really important. Public health in our model manage the isolation and contact tracing aspects of it. Secondary care, knowing who you're going to call. If you need to send someone to the emergency department, that's straightforward. But do you have a connection with someone with COVID experience who you can call if you know the patient doesn't need transferring, but you just need some advice? So developing that relationship. Oxygen providers for those palliative stream patients. And community care providers, so that if somebody needs urgent home care in the home just to be able to maintain them safely, that you know how to and can rapidly access that. and understanding who will be in your practice will be responsible for tracking active patients. So my final message really is that primary care and mild to moderate COVID, you've got this. You have all the system features in place necessary, and with a clear pathway, access to pulse oximeters, and a system-wide approach, we can really provide excellent care for our patients. And I could say that with our model, we're just in the middle of doing the evaluation, but our early analysis of the data, it looks like that the mortality rate was 0.6% in this primary care model, remembering that we pick up all patients at the beginning, and then those with serious illness go on to hospital. So it compares extremely well to what we know of the population level mortality rate. So you can care for COVID in primary care with great confidence that the outcomes are going to be good for patients. So thank you very much for inviting me to share with you this evening. Happy to connect with anyone by email, and please use these resources and adapt them for your own setting in any way that you think might be helpful.
Okay, well, that was great. Christine McIntosh will be speaking next. So Christine is a GP in Auckland and works as one of the liaison doctors through Counties Manukau. Is supposed to be working 20 hours a week, but I think she's been doing 20 hours a day lately. She's also in charge of, my understanding is, this community-based program that we're heading into. So Christine, we've got lots of questions, so over to you.
Bruce, thank you. Thank you. I wouldn't say I'm in charge of it. I'm providing clinical advice to the COVID care in the community at the moment through the NRHCC. So thank you very much, everybody who's joined tonight. And it's a pretty hard act to follow all the previous people. But what I hope to share with you now is just where we were up to really with where we're planning to go with the community support for isolation and quarantine at home. We really had to sort of adapt quite quickly. So up until recently, you know, Lance and Stephanie were managing all of our cases in quarantine, and that was our public health setting that we needed to have everybody in quarantine. But that was obviously going to be a problem at some stage, and we've now hit that stage. And so we now have this interim model where we've extended the knowledge and abilities of our quarantine clinical team and extended them to looking after people in the home setting. So there's been some rapid adaptation and managing that. Now, more recently, we are also bringing along Whakarangaho Healthline to assist with that model, particularly from the monitoring point of view of it. So from early November, we're going to be transitioning, and that's really giving us a little bit of time to get all the systems in place that we need to move to also a Māori and Pacific provider model and to general practice model of care. So the really important things are really about establishing that coordination hub, because that helps to make sure that we're not losing anybody. And I think perhaps what I would reflect that the position that we find ourselves in New Zealand is we've got a very strong public health response, and that's because we've been in an elimination phase for such a long period of time, and we've learned really well how to suppress this virus. So we find ourselves in the setting where actually the public health component has a very, very strong role at the moment in how we're managing cases of COVID. So it's also the transitional model, and what we're doing is working through all of those things, and I could see all the stream of questions coming through about, well, how's St John's involved, how's hospital and the home involved, how do we get a pulse oximeter, you know, how do we do all of these things? And I think that we have had somewhat, you know, the ability of not being completely overwhelmed with numbers of cases and just having to cope, but actually have the ability to set up that sort of central coordination and do things quite well. I think it's also really important just to reflect that many of our people who are suffering from the COVID at the moment are our Māori and Pacifica populations, and have, you know, really some of them quite complex things that they might need assistance with. So that's a really important context, I think, to the current outbreak. And from there, it's about scaling up. So it's really embedding models and scaling up from that point of view. I'm just really aware I don't want to take up a lot of time because I'm sure people have got a lot of questions. So just really to take you through the current patient journey in Auckland. So Auckland Regional Public Health Service receives that positive notification. The patient gets notified by Public Health, and then they undergo quite an interview really to find out at this stage whether or not it's likely that this case will be able to be reliably isolated at home. And that's and effectively, and that's all about that person's context and their whānau or household context or their bubble. And so those are the things that the medical officer of health take into consideration when they're deciding where the right person is for that person to be. So at that point, they allocate them either to the managed isolation quarantine facilities, to isolating at home, or if they're particularly unwell, they will send them off to hospital. Also recognising that we also have alternative pathways, so we know that people are also found to be positive when they're in hospital, when they turn up. So there are alternative pathways into this. Currently, that is a little bit of a bottleneck for us, and I think, hearing from our speakers tonight, that's the really big focus for at the moment, is really speeding up that process of getting people under that medical care at that point in time. Now, what the concept is a coordination hub, and that is making sure that we are able to provide that whole Manaaki function. So the Manaaki function is perhaps the biggest piece of work actually at the moment for supporting people in the community. And that Manaaki is about what do we need to, or how can we enable support people to effectively isolate at home. And that's things like actually getting food, getting baby supplies, getting the things that people need so that they can stay in their homes and isolate effectively. And it's also talking through the consequences of isolating at home. And that can be quite tricky because it's about that case and then the subsequent cases. And every time somebody becomes a case in that household, everybody who's not a case then resets to a 14 days of isolation. So it can be a really prolonged period of time that the public health requirement is that they isolate in that home. And so it's really actually preparing people for that concept, which is quite a hard one. And especially really hard if people actually not feeling particularly unwell as well, which is happening because we've got people who are vaccinated who do become cases, or they're quite young. So then from the coordination hub, it's about then, figuring out who is going to do that healthcare monitoring. And at the moment, we've extended our quarantine team and their expertise in this situation, and then extended out to Healthline. But the next thing is to really figure out how we get the Māori Pacific providers and general practice on board. Okay, and then there's also the thing about how could we create facilities for people to be able to be seen in the community if they do have COVID, and how do we create those red stream clinics where they can go? Just to really state that there's actually a whole piece of work going on around a Māori model, and that's really about a kaupapa Māori model, and just understanding that actually is, I think Tim and several others have said, it's actually the psychological burden of having COVID is quite significant, and really reaching out to the communities to say what can we do about making a really robust model for Māori to make sure that we are supporting them through this COVID journey. And really taking that opportunity, if they're not already linked into the whānau ora kind of models of care, it's really awhiing them through that whānau ora kind of process, and really enabling them to be effective at isolating at home, but also taking that opportunity to see what else can be done to really strengthen that whānau well-being. There's a lot of thinking going on at the moment, because not only do we have to think about the clinical risk for people, but we also think about what their social needs are. And so there's, that's really a lot of the factoring in to think about how people can isolate effectively. I think just for your interest, down there in the right hand corner at the bottom, I did a rough calculation of the cases in the last week, and really just stratified them by age, vaccination, by ethnicity, and risk of more serious COVID disease by ethnicity. And that was the work by Michael Plank and so forth that allowed us to know what our local figures would be, and just really broke it down to what we'd anticipate might be the risk levels of more serious COVID amongst the current cases. Now, clearly I didn't adjust for any comorbidities, because this was just done purely by the figures of cases and their ages and ethnicities. but just to give you some idea about what we might be expecting. Just so you know, for people who are isolating in the community, what they might be expecting at this point in time. A lot of the public health advice initially is about how to mitigate risks for other household members. There isn't a comprehensive bubble assessment done by public health prior to them being referred on to really see what can, where they should be. Once they're referred on to the community C-SIQ, fondly known as C-SIQ and NRHCC, they do a virtual check-ins and they set them up with a pulse oximeter. And that's really, actually, pretty much every family is getting a pulse oximeter, and that's sent out centrally. And we do have a good supply of that, and that is sent with an information pack. And Dee's advice on all of this has been really, really helpful, developing up all those resources and so forth. There's a lot of provision of Manaaki, so that's getting all those things that families need to isolate effectively. And then there's ongoing medical care. So there is that routine health questionnaire each day, somebody bringing up and checking on how people are doing. And then we've also developed the health pathway for COVID management. So the Auckland version of that is now live, and clearly as we keep adapting the model and so forth, we'll get iterations of that pathway. But that pathway was very, very strongly influenced by people who are on this Zoom tonight, but also by Dee's work and also the RPA Sydney virtual model as well. So we've got a lot of advice from overseas. So at the end, there's also a release assessment for people who are in that bubble. So once they're cases, they do need to be released from isolation, as do contacts. So that's actually part of the public health response. So that's really all I've got to share tonight. I think just realising that in New Zealand here, compared to perhaps Tim's experience and Dee's experiences, we have a very strong public health response at this point in time, and that is actually dictating some of the model of care at the moment. And there is a lot of work going on in the background at NRHCC to join up our digital healthcare, because a lot of the moment about how we don't lose people from the system is keeping it on the same border clinical management system, which is the practice management system for the quarantine facilities. That's how we keep an eye on making sure everybody is getting seen and getting sorted. And we're currently working on how we can manage to make this available within our primary care systems so that we can all contribute to care. So that's really all I wanted to say tonight, other than the fact that there is a Health Pathways webinar on next week on the 3rd. And I think that will talk a lot more through the New Zealand model of care. So thanks, Bruce, over to you. I'm sure there's a lot of questions.
Okay, Christine, they're rolling in. Question for you, Christine, pediatric for children's pulse oximeters. Then I've got a few questions for Tim. So they're rolling in.
Yeah, so my understanding, the pulse oximeters are not specifically for children, and the advice we've had is you generally don't really need them so much for the children. I think there would be specific cases where you might, but in the most, I don't think you really need them, but Tim might be more expert at that than myself, and Stephanie also might be more expert at that than myself.
Tim, do you want to make a comment?
Yeah, I mean, I'm speaking out of turn, really. My wife's a pediatric ID, or nearly consultant, and their observation in London was that the kids did really well, and the same outpatient monitoring considerations weren't required, apart from maybe some really niche cases, but those kids generally are known to the paediatricians.
So this might be a good question for you. Any difference, any sort of clinical difference, do you think, between the Alpha and the Delta variant? Would you notice that, or is it more a gut feeling?
Interesting you say gut. Maybe a bit more gut stuff. I guess the major thing that I noticed with the remote following was that with Alpha, all of a sudden whole households were sick, where that wasn't the case with the earlier variants in Wuhan, and then Delta even more so, and everyone was all sick at once. But in terms of clinical trajectory, apart from probably being slightly quicker, people hit that tipping point a couple of days earlier than the original Wuhan virus, and that would make sense with the increased viral load and infectivity of Delta. No, the clinical features, particularly for hospitalised patients, are pretty similar. There are differences in the cohorts, and so our ICU colleagues have commented that they're seeing very different phenotype of people who end up intubated. but it's just a completely different landscape to those very early, you know, like you mentioned, Christine, and sorry, Dee was talking about the old people who suffered in Italy. You know, it's just a very different landscape that's getting infected now.
A couple of other questions for you there, Tim. Any benefit from cough suppressants? We know that with other viral illnesses, they're fairly useless. But did you find any sort of symptomatic benefit in London?
No, I mean, they're still a bit useless, but some of them taste nice. Yeah.
Invest in them because they've got a good share portfolio, but don't use them, I say so.
Yeah, exactly.
And the other thing was secondary bacterial infection, a bit of a chestnut in primary care. I don't know what the questionnaire means by that, whether they're meaning pneumonia. Did you see many true bacterial pneumonias?
Excellent question, really important point. This has been the focus of randomized clinical trials of doxycycline and other agents for that exact issue. We didn't see any bacterial infections really coming into hospital, and the RCTs of administration empirically of doxycycline for people with community, you know, not non-severe COVID-19 showed no benefit. So effectively, I think it's very safe to say if you've got someone with COVID-19, they do not have a bacterial infection, unless there's a really clear evidence to suggest that, like, they've got a wedge-shaped, you know, thing on a chest X-ray, which is generally the hospitalized cohort. So no, I'd say you can never say never, but no.
A question for Stephanie and Lance about dealing with addictions and nicotine in managed isolation. What would some of the? I know you mentioned the psychosocial stuff, Lance, when we had a chat.
I think, look, Stephanie is the absolute national expert on this, having looked after large numbers of people. Stephanie, take it away.
I think it's been, thanks, Lance. It's been a huge, I can't lie, it's been a real big issue for us. So, and I think there's, right now the COVID went from moving into it from a church cluster to it's embedded in transitional housing, and there's definitely addictions issues, which we've had to develop some pretty close relationships with CADS. And smoking is a real significant one, because I think when people are coming off of drugs, smoking is something that they want. And I think we've worked really hard. We do nicotine replacement, but people aren't open to that necessarily. So it's been a real challenge. I can't lie, it's been a real challenge. CADS has been, I just think CADS has been amazing, and they've really supported us and just getting as much information as we can for people. But it is a significant part of the outbreak in Auckland at the moment.
There's been copious amounts of quetiapine, diazepam, and zopicone prescribed. Yeah, it's been a real challenge. But working again closely with secondary, tertiary colleges is really helpful.
Well, as Professor John Werry used to say, most New Zealanders are, not all, most are mildly to moderately addicted to alcohol. I think if you get put into a soft prison, which is MIQ, then I think the people really start to feel it. Any thoughts about that, Lance?
Well, yeah, that one thing that Stephanie's talked about time and time again is this is a forced, withdrawal or detox program. These people don't want it. Whether it's an MIQ or in their home, they're going to be forced to stay there with limited access to their, whether it be alcohol or drugs. And so you're managing a population that are upset because they're COVID positive, upset because they get their substances of abuse, and then other social issues. And then on top of that, they can become unwell. So it's incredibly challenging. We've had a number of people that are in the hotel drinking huge amounts of alcohol. Otherwise, we're managing a detox and acute withdrawal and getting quite sick.
A couple of questions, maybe for you, Christine, about what's going to happen when, or Tim also, what's going to happen when the hospital system is overloaded. And we've got a colleague from Wairoa who says it's 2 hours to Hastings, and they can see themselves getting overloaded fairly quickly. Anyone want to make a comment on that at all?
Well, Gary might be able to make a comment, I think, as well regarding the hospital, as well as Tim, perhaps.
Yeah, okay, Gary, front line now.
Yeah. Yeah, well, that's certainly what the resilience planning is about. And given the size of the vaccination and the caution that the government's shown, yeah, I'm quietly hopeful that we won't get to that overwhelmed stage. Yeah, we did a webinar with colleagues from Liverpool Hospital in Sydney about how stretched they got, and I just can't see us getting even to that stage, let alone to the London stage. So I'm relatively confident about how it's going to pan out over the next 2 or 3 months, and then next year, yes, fingers crossed.
A question for a bunch of you: is supplying thermometers another useful thing to do for patients?
So I did a lot of surveying of the international literature, and the general feeling was it didn't really help a great deal. You know, people say they've got a fever, they've got rigors, they've got rigors. It doesn't greatly add a lot of value. The benefits in the pulse oximeters.
Tim, any comments on that? You're shaking your head.
I mean, yeah, agree. We didn't have the resource to even consider it, but you just trusted people. You know, they're in the right phase, feeling febrile. Say, I feel hot and yuck. You trust them.
Well, I know Mark Thomas presents stuff, and in a bunch of normal people, the temperatures go from 36 to 38.5. So-called normal people. So I mean, it's hard to know what normal is, isn't it? Really. I mean, it is part of that, you know, contextual assessment that we do all the time, basically. And it sounds like you need to trust your instincts if you're going to be referring people to hospital early. I get just a comment here about the public health units are getting very, very tired with long hours and complex cases. Having worked in contact tracing for some months, this is not sustainable in the long term. So maybe Gary or Christine might want to deal with that one.
Yeah, I mean, we certainly have quite a strong public health response, don't we? And I guess the question is, you know, at what point does that change? And that's not our decision to make. But Gary, do you have any comments on that?
Yeah, I think you can see it started to change in the Auckland context already, that it's not trying to eliminate, it's trying to suppress, trying to mitigate, slow the rate of progress. And that's much less resource intensive than trying to find every last case. So I think you can see that switch starting already, and that'll carry on. It's still really important that our public health units do the isolate and slow the progression, because even at 90% vaccinated, if you get to that, you're still at a large chunk of the population that this virus can go through if you let it just go willy-nilly.
Maybe a question for Lance and Stephanie.
I'm just going to say, Bruce, the obvious thing is to get into every corner of our country and vaccination. That's really a high priority at this point, because this is our best way to manage COVID.
The virus will find you otherwise.
Well, that's right. We're all going to be exposed to it sooner or later, aren't we? Lance and Stephanie, question: what happens if a COVID patient needs sutures or something that requires a face-to-face visit? Or what, maybe Christina, maybe how's that going to happen in the new system?
I think, yeah, that's interesting. I mean, like practices, if they have read streams, Christine, I think if I'm correct, you know, that they can have people that are symptomatic. I'm not sure if that means positive patients as well coming into their clinics. Christine, are you able to?
Yeah, so I think we're working with our primary care colleagues in Auckland at the moment to think about how we can actually achieve that. So it's a little bit of discussion about whether it's actually better to go and do a home visit or whether it's better to do it at a clinic. And we're actively working with our primary care and PHO colleagues in Auckland to figure out how we're going to achieve those, you know, who's willing to do that red stream clinic. And essentially, you know, we're really good with our PPE now. We're really good with our red streams. You know, practices have done an amazing job to adapt. And I think it's just knowing that somebody's COVID positive and bringing them through in a safe way to give them the care that they need is really, really important. So that's an active piece of work in Auckland.
Can I just make a point that you know, in Jet Park, you know, where they've had, you know, hundreds of cases over the last 18 months, there's only been one of the health staff that have become positive from COVID, and that's despite the fact that they're up and seeing positive patients in very confined spaces, hallways, at the front, at the doorways of their hotel rooms. Almost every second room's COVID positive, and people are in there all night coughing and spluttering. And what's stopped more staff getting sick and infected is good PPE and good IPC protocols. And so, you know, Stephanie's seeing people all the time positive. I am, all our staff are. the reason we're not getting sick is because of this. Now that primary care can feel confident too, that they can see COVID positive patients if they have really good PPE, and everyone does this. It can't be just the doctor or the nurse. It's got to be the whole crew. Then you'll be safe. Is there a risk? Yeah, absolutely. But like of the many cases that have occurred in staff and MIQ across Auckland, there's only been 2 at Jet Park where all the positive cases have been. So, and it just shows that good PPE and IPC will keep you safe, because then you can still do more for these people. They don't need to go to, say, hospitals all the time just because they got COVID positive and they got a sprained ankle, or they need stitching. I would encourage primary care to sort of, be really good at that and still be able to provide that level of care that they need.
Christine and Tim.
Thank you. And I think I've seen a few questions asking about funding for primary care, and that's a very active point at NRHCC at the moment around how to provide at least some interim funding to primary care for activities that they might provide, care that they might be providing to people who are isolating in the community. So originally that was on the requirement of the public health requesting them to look after their patients, but we're just currently reviewing that funding. So that's just actively under review, and should hear about that through Medins very shortly.
Tim, do you want to make a comment on that?
Oh, look, I was just going to completely emphasise what Lance has been saying. And, when you hear these stories of healthcare workers getting sick overseas, they're getting sick outside of hospital or from their mates in the tea rooms. That's who I blame anyway.
Just a question maybe for you, Tim. Somebody giving antibiotics before a diagnosis of COVID. I'm sure you're presumably after exposure. And the role of prescribing Ventolin and prednisone. Lance, Stephanie, or Tim on that one, I think.
So I guess I don't know if the question was, you got somebody who's got a cough and a sore throat and you don't know they've got COVID and you prescribe because you think they've got, bacterial pneumonia or something like that. I guess you just stop if they get their COVID test back. In terms of systemic prednisone, systemic corticosteroids should not be given in the community. There's this trend towards harm in people who don't have an oxygen requirement. And that's one of the key messages for getting people in who are hypoxic, is that's where you hit your threshold for benefiting from some of the hospital level treatments. And so that's why the message is, come into hospital if you reach that level of hypoxia, because there's things that we can do to treat you and to make you have a better outcome. Obviously, people might have seen in the news that there are new exciting things happening in the community treatment space, and things like this named after Thor's hammer antiviral treatment that hopefully will be an exciting option. So I guess the future's bright for other early treatment options and community, because that's where everyone's focusing on.
Any value of Volcadine or codeine at all, do you think, for coughing?
Stephanie, have you guys been using it?
Yeah, look, one of our doctors has made a mention of that tonight. We sort of discourage it for people who've got productive cough. And, if someone's had 2 or 3 days of a dry cough and it's annoying, we sort of say, look, persevere. But, someone who's 7 days and maybe more, look, it's you've got to be trying to do something, and it may have a small effect. So we do prescribe Volcadine. Hey, just a question. Can I steal a question, Bruce?
Yeah, there you go. Yeah. If you see a question, go for it. I've got 81.
One of them is a delay in getting notification to general practice about COVID positive, and that's a real problem. And that goes back to the point of public health being under such pressure. I would say to a primary care out there, educate your population of people and say, look, if you do get COVID, please let us know, because you may let us know before public health let us know, and we'll be able to help you sooner. So that would be a really good thing you could do. Maybe some way of messaging that out to your community. So because that happened with the case I talked about earlier, the pregnant lady, we were still waiting. AFs have to go through, well, first of all, they have to get a positive result, then they have to do the scoping, then they have to arrange a referral to the MIQ or S-IQ. And it can take a long time before it gets to the GP getting notified. So that would be one thing. Another really good question was who determines whether MIQ or S-IQ, so community care or MIQ. And at the moment, it's as I understand, Christine, it's around a public health triaging. So if they can't stay at home safely, then they go to MIQ. I don't believe there's a real clinical weighting to that in terms of medical issues, but Christy might be able to confirm that or otherwise. I think that might change, but at the moment MIQs are being used from a public health point of view, so as I know.
Yeah, so that's my understanding that public health are not making the decision based on medical needs, obviously, or clinical risk. It's obviously if they need to go to hospital, they need to go to hospital. It's more about their ability to effectively isolate at home. Yes, I agree, there is a delay at the moment because of the public health process and our very public health driven response to COVID at the moment. So yeah, but it would be ideal to prep patients and let them understand that, if they know that, they can contact their GP. Yeah, thanks, Lance.
Just in terms of timekeeping, I think we'll go over to 9:15 because the questions are increasing rather than decreasing. I just asked the speakers if they could have a scoot through the questions. Just put your hand up if you've got a question. Lance, you want to have a go?
Yeah, there's lots of really good questions. One is around inhaled corticosteroids. So we've been using that for a wee while at MIQ, which is 800 milligrams of budesonide twice a day. And we initially started with people over the age of 65 would all be offered it, or 50 with comorbidities. Recently, the ID and respiratory teams have said, particularly, look, you could push that age limit right down. Anyone who's got obesity related issues, respiratory issues, other chronic health issues, you could be offering it to them, and it reduces, it can reduce hospitalization and death, but it improves recovery time. Some of the practicalities around that is keeping in contact with your chemist, saying, did you have the 400 microgram tubular? Because it can be a bit problematic giving someone a 100 microgram one, and then having some good information for the people on why, because they're going, well, I'm not asthmatic. Why are you giving me, an asthma inhaler? It's 14 days. So it's something to think about, but that was a good question. And so I'd encourage primary care to be looking at that quite early.
Yeah, thanks, Lance. You following on from that, I think we're going to be including that formally as a recommendation as part of the national guidelines. So that'll be in the treatment space. And I guess relative to some of the other new treatments that may be superseded, if other stuff it does hit our shores, but awesome option if you've got access to it in your community.
Anyone want to make a comment on the palliative care situation? So it seemed like in Ontario they'd leave the palliative care people out of hospital and give them oxygen at home. I mean, any experience here on that?
I guess the way that we saw palliative care's role was really key for care for patients in the hospital, and making decisions about who, as part of their advanced care planning or sort of goals of care, decided that they didn't want to be in hospital for their worsening COVID illness. And so we incorporated palliative care, really early into the treatment journey. And I guess if you do have relationships with patients and that it's part of their advanced care planning is not to go to hospital if they were to get sick enough, then early chatting with hospice and discussing goals of care after soon after their diagnosis would be a really sensible thing to do, just like with any other disease process, but it can be done really well, the palliative care of people with COVID.
Christine, notice there were a number of questions there about doing after hours. My understanding in Ontario, if you were to volunteer for this sort of after hours work in a practice, there'd have to be after hours cover, but it wasn't too burdensome.
Yeah, I think
planned here.
Yeah, so it's quite important, doesn't it? And that's really, we did a survey in Auckland recently to ask about people's, primary care's feeling about what they might want to do around COVID care. And I think that we need to sort of recognise, I've seen another question here from Anna saying, what's the plan for large clusters of COVID positive patients in the community all associated with one GP? And we've got to recognise that, we've got to have some backup, haven't we? We've really got to have the ability to share the load across the system. And I think it's also recognising that actually we're slightly different, and we are different because we've got quite a vaccinated population and a younger population who are getting COVID at the moment. And yeah, there are some surprises, as Lance is talking about, but there are quite a few people who are only mildly unwell with it at the moment. And so how do we share the load across the system? So a lot of thinking going on about that, how, you know, Healthline might be our you know, our 24-hour service, for example, you know, the 7-day-a-week bit, but actually, you know, thinking about what the blend is there. But I also think really thinking about this development of the Māori provider sort of concept as well, and that's sort of the Manaaki concept of along with that. So it's not just about the health response, it's also about all the other response that needs to go with that. So yeah, there's lots of thinking about it, lots of so it's, you know, watch the space, I think, is the answer to that. But I don't think we're going to leave practices to manage 24 hours a day, 7 days a week. I think we really can build a, you know, a system that helps everybody.
Question about COPD, patients with known COPD, and I imagine that gets a bit tricky. Tim, would it? Any thoughts on advice?
I might ask Lance and Stephanie, how have you guys been managing your people with asthma or COPD who you've had through? Because we didn't see many. Like, there was the thing that surprised us, you know, in that first wave. We're like, oh my God, all of this, you know, people with the lung diseases are going to come through. But it wasn't, you know, it wasn't, surprisingly. But in central London, where everyone was smoking, and there was a lot of COPD, but we just didn't see it. So, I mean, some asthma we'd see, but I don't know if you guys see much.
It's interesting that the cohort we looking after do have a lot of, you know, airways disease, smoking related. I have to say I haven't seen that being a significant problem with us. Yeah, so Stephanie, any comment there?
No, I think I agree with you. We haven't seen that many. And I think we've just treated, a few people have actually been treated in primary care before they've come into us, before they tested positive, and they had some, you know, prednisone before, because they presented with a viral type infection, because we haven't really had any much complexity.
Hey, Tim, question for you.
Yeah.
If you have a person who has reversible airways disease and, you know, they are having increased shortness of breath, you know, viral exacerbation of their asthma, say, they're needing more Ventolin, can GPs look at giving prednisone to these people? I heard earlier maybe they should be, if they need that, they should be going to hospital. That could be quite a overload on the hospital system. Yeah,
no, really good point, Lance. I guess the systemic corticosteroid for COVID pneumonitis is for the people who are hypoxic because of their COVID. I mean, if you've got think someone who's having an asthma exacerbation, then yeah, treat them as you would normally. And it might be that they get some corticosteroids. I think I'm trying to remember how he worded it for the guideline, which we just nicked from the Aussies, this section, but was I think it was steroids as for usual indications, just to continue and don't adapt the dose. So yeah, treat asthma as asthma.
Cool. Hey, Bruce, I've got a question from Andrew Brown about where's a sort of a place that people can get information from, you know, clinicians, you know, where can they get advice? We're really lucky because we do have good relationships with the consultants. We have every day we have the Audi meeting at 9:15. That's not something everyone can jump onto, but you know, I know there's an on-call consultant at North Shore, Auckland, and Kane's Manukau, so that's a absolutely great starting point. But I'm not sure whether there's a vision for having like a COVID helpline for clinicians in the future. That would be really useful.
Good question for Christine. Do you want to answer that, Christine?
Yes, so at the moment it's on our health pathway, and you can find there who to contact when you're concerned. So so you'll find that on the Auckland health pathway of COVID management. And that's really an active piece of work that we're working with Tim and others in the hospitals to say, actually, how do we manage this to make it manageable for everybody so that GPs can get advice when they need it, and Tim can get on and do a ward round when he needs to. So it's about managing that in a management, you know, and at the moment I understand that the 9 o'clock session goes pretty well every morning, and you guys work through your sort of virtual ward round together, and that works really, really well. And I think it's about how do we scale that up when we need to scale that up. And that's really active discussions at the moment, and with our secondary care colleagues about how we make sure we've got that access to advice when we need it.
Presumably the ID physicians are going to need a bit of protection, aren't they? Well, what's it like for you, Tim? I mean,
oh, look, I'm the new kid on the block. You know, I've only just got here, so I probably couldn't speak to that in behalf of my colleagues. But yeah, I mean, it's busy, right? We're all busy. Everyone's busy in this work area of work that we're in. But I guess what I can say is that the team in secondary care are acutely aware of the community burden, and we're really committed to trying to help get everybody into the same playing field. You know, we really are all in this together. And this next few months in particular, we'll all be working hard to make sure that we can get into a steadier playing field where, you know, life's a bit better.
So Tim, we're going to have to be talking to our patients about the long COVID and what things are likely to be permanent and what things are likely to be are going to get better. A friend of mine in Canada, his daughter got the respiratory thing in Toronto. And she couldn't walk to keep up with him. He's my age and she's 35. And it's gradually got better, but presumably there's going to be a bit of residual damage, and we're going to be picking that up with our patients, aren't we? Any advice on that?
I mean, it's a really interesting question, and the short answer is we don't know. Like, the hospital I was working at was a sort of ridiculously resourced central London place, and so they had one of the earliest and I think largest post-COVID clinics. And still being surprised, you know, things that we would have seen on a CT and say, no, that's scarred, that's fibrosis, that's there forever. You repeat a CT 3 months later, it's all gone. So there's a lot about this post-COVID situation that is really unclear. I guess the message is that for most people, even if it's a protracted recovery, there is a recovery, and just a lot to learn in that space. So I guess I'd be cautious about sending a message of nihilism to that group. So it would be one of support, interest, curiosity, and helping to work with the individual for what their problem is. And I know that the secondary, I can't speak for my colleagues, but the secondary care clinicians are aware of the impending increase in people who are experiencing persistent symptoms, and we'll be looking to support this best we can.
Tim, one question there about the role of culture scene. Any role of culture scene in COVID?
Oh, so hopeful for culture scene. You know, wouldn't it be great if dexamethasone and colchicine, cheap, you know, worldwide available drugs, but unfortunately, so the recovery trial, which has driven so much of this, you know, UK-based huge numbers, because unfortunately lots of cases coming through, demonstrated no benefit from colchicine, unfortunately. So that one's off the list, I think.
Because there's a bit of a feeling out there that the big drug companies are stopping the ivermectins, the colchicine, but apparently Merck have suggested that in North America ivermectin not be used. And I thought, well, that must be a bit of a first, a drug company saying don't use our drug off-label. So yeah, I mean these things have been tested, haven't they? Doxycycline, colchicine,
Yeah.
they've all been tested.
Yeah, it was really interesting being in a you know, huge academic centre with, you know, academics everywhere, and that's sort of part of how the NHS coped with that response, is that there were people to pull out of their labs and they didn't have anything to do. But all of a sudden these projects were stopped, and there were academics who were looking for projects and things that were going to get funded, and so that's why there's just been this explosion of COVID research and people able to answer these questions rapidly. So yeah, everything that's been recommended for and against treatment has just had, in the shortest possible time, you know, the highest quality of research go into to answering the question and answering it in a meaningful, sustainable way. There's, you know, with these platform trials that you can pull one thing and out when it doesn't work, and then put something else in that you think might be exciting. So the research landscape is really really fantastic and is informing what we're doing on a nearly weekly basis. Yeah. So again, I guess on that point, the guidelines and the guidance of managing people will change very frequently, just reflecting the way that the data is coming through. Yeah. And you can rest assured that there are groups of clinicians and you know, from many different specialties who are sitting together around virtual tables like this on a weekly or fortnightly basis and appraising that literature for the New Zealand context.
There's no great conspiracy, is there?
Not that I've been invited to.
So I'll just ask the various speakers. So Lance, Christine, Gary and Stephanie, if you'd like to make a final comment, and then we will wrap up so that you guys can get a bit of rest for the big day tomorrow. Lance, do you want to go first? Any burning questions you see there, or final comments you'd like to make?
Oh yeah, I think it's harnessing the existing knowledge that primary care has with their communities, with some new approaches, which will include sort of virtual management, and using monitors, any monitoring equipment as able. I think, and listening to the people in the community, the families of the people we're looking after, and then getting advice from our colleagues in the hospital, which I think sort of those are the ingredients for getting through this.
Christine, do you want final words or big questions that we've been outrun by the questions?
Lots and lots of questions, and I've been having a good look at them too. And I think there's lots of questions there about funding and models of care, and how GPs will go about that. And look, I'm also part of the National Clinical Advisory Group, and there's lots of work going on from that point of view to establish models of care and funding packages and all those sorts of things. There's all in the mix at the moment and being discussed. So and sort of planned for. So I clearly that's not quite been decided yet, and so I just encourage people just keep wait. What's being decided. We've got very strong representation in that clinical advisory group from primary care. So just bear with us as we keep doing that planning and get that in place. Thank you. It's been a brilliant night. Thank you, and I really personally thank everybody who's helped to come along to this webinar tonight and talk to primary care. Thank you.
Stephanie, final parting words.
Somebody was talking to me about, we saw a few questions about pediatrics, and I guess one of the things that is a bit of a learning pearl for me is not to forget normal pediatric stuff. The kids might do well from COVID, but we actually picked up quite a few cases of kids presenting with sore throats or fevers that actually we picked up group throat swabs. So these are these are large families that are isolating in houses, all close confined spaces. So when you have kids presenting with COVID symptoms, it's good not to rule out that there could be other things going on.
Gary, last words from you?
I guess just a big picture thing. We've been quite smug in New Zealand for the last 18 months about how well we've handled COVID, and given how the vaccinations got and so on, we've got a real opportunity to be one of the best countries in the world at changing from a COVID-free place to an endemic COVID place. I think, I don't think any country in the world has managed to do this without a large number of deaths and overwhelming their hospital systems at some point. Watching how Taiwan and Singapore are kind of doing it at the moment. And I think we've got a real opportunity to do it as well as anybody has done in the world.
And Lonely Planet saying Auckland or New Zealand's the place.
Place to be in 2022. Yeah.
So I'll give it as a welcome home present for Tim. I'll give you a last word there, Tim.
Oh, look, it's been an absolute pleasure, Bruce. It's wonderful to be home. It's been a really surreal 18 months seeing how New Zealand's been doing from the other side of the world. And so to be here, obviously my timing is terrible, but it's really cool to be here, and it's wonderful to be able to work together with such wonderful people. And like had been said earlier, I think the best thing that has come out of this pandemic is the collaborative relationships that have been built and strengthened through having to cope with adversity. So I think it's a really cool time to be working in the healthcare sector in New Zealand, and I think we will change the way we manage our routine patients as a result of the ways that we've had to think about dealing with COVID. So yes, stuff ahead of us to do, but exciting as well.
So I'd just like to thank all our speakers tonight, because I know they're all working over and above the call of duty, which I think that will apply to an enormous number of people who have been watching this tonight. But this is very exciting, I think, to have had this evening. So thank you very much, folks, and brilliant to see all of you, and lovely to catch up with all of you again. So over and out.